All right. Good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter today, Dr. Timothy Wiemken, who will be presenting on the topic of antimicrobial stewardship. Are we missing something? At this time, I'm going to stop sharing my screen and turn the presentation over to Dr. Wiemken.
Excellent. Thank you very much. Chelsea, can you hear me okay?
Can hear you just fine.
Perfect. Share my screen here. All right, go. Okay, so we're going to talk about stewardship today, but not just antibiotics. I hope that's okay. So Tim Wiemken, I'm a global clinical epidemiologist at Pfizer, and everything here is me, it has nothing to do with Pfizer, which is great. So we're going to kind of tell a story like a movie. I'm a big horror movie fan, so we're going to try to make it scary too. And of course, the end of the day, no resolution because we still don't know what's going on with stewardship. So curse of the thoughtless man. So we know from essentially the discovery of antibiotics that there will always be a bacteria or some organism that is resistant to that antibiotic. And we knew it from the beginning, and it's still a problem. We haven't really done a whole lot about it, but of course now we have a mess of antimicrobial resistant organisms. We know how this happens. It's not like some spontaneous thing. Organisms are already resistant. There's just fewer of them because generally building those proteins to build efflux pumps or whatever to pump antibiotics out or change the ribosomes, it takes more energy, so they're not as fit. But if the other ones are being killed, then the resistant ones can kind of grow and take over. And this has been happening for millennia. It's ancient. Since the beginning of life, as we know it, then there's been resistance to drugs, medications. So if we look at a timeline of all of this, Fleming publications about penicillin in the 20s and penicillin production in the early 40s, and you can see at the top the penicillin-resistant Staph aureus emergence just very shortly after beginning penicillin production. In the 50s, we had methicillin, MRSA right afterwards. In the 60s, we had vancomycin. We probably didn't use it as much, but we eventually saw resistance. And of course, now we have vancomycin-resistant staph. And you can continue this on with daptomycin, linezolid, whatever, and you're always going to see resistance shortly after for the exact reason that we described earlier. The organisms already exist. At the top here of this slide, you can see antibiotic deployment when the antibiotics were actually released to the public, and the bottom when resistance was observed to that antibiotic. So you can see generally, for the most part, within 5 to 20 years, you're seeing a pretty substantial burden of resistance to the drugs that we released. It's hard to keep up, very hard to keep up. And then we have more global problems also. So multi-drug resistant tuberculosis, we all know tuberculosis kills many people throughout the world every year. If you look at this map, you might be like, oh, wow, look, Russia has a lot of big percentage of multi-drug resistant tuberculosis, but that's not why I wanted to show this slide. The reason I wanted to show this slide is this: no data. You go back here, look through Africa, in the Middle East, there's a substantial burden of countries that have no data reported. So how do you develop an intervention to improve antimicrobial use or therapeutics for TB when you have no idea what's actually occurring? You can't. So we don't do a very good job of surveillance for all of this. Again, there's another look at places with no data on bacteria antibiotic resistant pairs. And even more than that, there's a lot that just have very few. So it's not just not having any data, but there's a very limited data in a lot more countries as well. So we have to have these data, and we're improving over time. This slide at the top from World Health is 2017, 2019 in the middle, 2021 at the bottom. And you can see the white areas that are not enrolled in the GLASS project, the antimicrobial resistance project, is decreasing. So we're getting more countries involved in data collection so we can do a better job of developing interventions. Of course, we know that we have to have data to support any intervention that's actually going to be useful, that's actually going to work. Has to be data-driven, has to be scientific. And why is this? Because a lot of people are dying from antimicrobial resistance. Here's the forecast for deaths attributable to AMR by 2050. Every year by 2050. It's an insane amount. It's an insane amount of people. 5 million people in Asia. If you look at the overall burden comparing antimicrobial resistance, again, this is kind of, it's a little bit unfair because it's a big pool, MRSA and all these other organisms, but you compare that to traffic accidents, compare it to measles, diabetes, we're dealing with magnitudes more deaths due to antimicrobial resistance than many of these other things. We need to put a lot more effort into data collection, into scientific intervention development. So let's go back a little bit further. In 1879, Edison said this. You've probably seen this quote somewhere when he was trying to develop the light bulb. I've not failed. I've just found 10,000 ways that it won't work. Some people would say, oh, what an optimistic way to look at things. But more importantly, it's knowing failure, identifying failure points. So when it comes to antibiotics, we know we've failed pretty bad at deployment, data collection, intervention development, regulation, and being able to use these properly. But what about other things? So it's not just antibiotics and medications that we take orally or injectables that are killing bacteria. We use tons of things that are killing bacteria, yeast, fungi, whatever. And those are also antimicrobial. So when we talk about antimicrobial resistance, it's not just antibiotic resistance. It's not just antifungal resistance. It's not antiviral resistance. There's disinfectant resistance. So our use of disinfectants, we know now there are a pretty substantial burden of disinfectant-resistant organisms. We'll talk more about this in a little bit. Many articles on biocide resistance. And of course, during COVID, we saw at the beginning, think back to what seems like 100 years ago, but mid 2020, when the pandemic started, and you went to the grocery store with rubber gloves on, and you wiped down your plastic bags with disinfectant when you got home. I mean, we just tried to kill everything because COVID might have been there. SARS-CoV-2 might have been on something. But what were we doing? We had a big opportunity cost of killing everything else and trying to create this sterile environment. And the issues associated with that are going to only rear their head as we move forward past the emergency phase of the pandemic. And the same thing goes with antiseptics. Probably you work in a facility that uses chlorhexidine gluconate or some other skin antiseptic to bathe patients instead of soap and water. Well, chlorhexidine is a antimicrobial agent, and we just kind of blast it's a broad spectrum antimicrobial agent that we blast everybody with 2 times, 3 times a day. Of course, we have resistance to chlorhexidine that is only growing in the community. Book chapters on disinfectants. Post-COVID, our overuse was so substantial that, again, keep an eye on this in the future, because you're going to see a pretty substantial issues associated with our overuse of all kinds of things during COVID. But of course, if we identify failure, then we can move forward. We have to know that we failed, though, and we have to be able to admit that we failed, because it's the most effective technique to know what to do moving forward. So what are we trying to do now? Well, CDC, of course, has their platforms for antimicrobial resistance, the core elements, but CDC is not really, it's guidance. It's not necessarily implementation. So the implementation phase, as you all have probably been acutely aware of, trying to implement large national guidelines is not really straightforward. So all of these ideas are really great and really important, but how do you actually operationalize this in a healthcare facility or a healthcare system? It becomes very difficult, especially if you're in a system that has multiple care settings. If you work somewhere that's acute care, long-term acute care, has a skilled nursing in it, maybe home health, the core elements are different for different settings, and it becomes very confusing to try to implement all of these things. But of course, we know that infection preventionists have a very useful skill set that can be applied to increasing the impact of resistance of AMR programs, but are generally underutilized. I mean, I think another failure point that we've seen thus far in antimicrobial resistance programs are the over-reliance on physician and pharmacists. Of course, it's critical to have those skill sets as leaders because they're prescribing, they know the medications, but they're not necessarily the data collectors. They're not the people doing the analytics and doing the training and doing the tracking and the reporting. So we have to have infection prevention involved in all of these. The program will fail without IP input. But we can kind of distill all of this down a little bit. I have to say that I've taken this idea from Dr. Ramirez when he started all of this, I think probably in the 80s. I know somebody said at one point that he's been an expert in antimicrobial resistance since the last century. I know he loves to hear that. But the four critical components of all this is having the right drug, at the right dose, the right duration, and giving it the right route. The issue with this, it can kind of work for antibiotics, but you have to know the pathogen. So we have empiric therapy where you kind of blast what's probabilistically going to cause the infection. And then as you identify the pathogen, you do pathogen-directed therapy, kind of narrow that spectrum of the drug to target just the bacteria so you don't kill all of the useful things, the normal flora. But that's not so possible with disinfectants and antiseptics. We don't have targeted therapies for antiseptics and disinfectants because that's kind of not the point. The point is to try to reduce the burden of kind of everything in the environment. But as you'll see, that may not be the appropriate way to do this stuff. All right, so we've kind of gone through all this. Let's talk a little bit about the curse of the outpatient. Go back to Ethiopia. So trachoma is the leading cause of infectious disease-related preventable blindness worldwide. And there was a great study that was done several years ago now and published in PLOS Medicine, where to try to reduce the incidence of trachoma-related blindness, they did a cluster randomized trial. So you kind of cluster, you randomize different groups of people into different therapeutic arms. So the treatment group here, all the children got one dose of azithromycin every 3 months. So a very small amount. I mean, if you get a Z-Pack, whatever, because you had a sinus infection, you kind of have your loading dose, your 2, and then you take essentially five doses of the drug. And this is 1. So it's even less than what you would get for going to urgent care and having sinusitis. So the goal is you take 1 dose every 3 months for 1 year to reduce blindness, chlamydia blindness in Ethiopia. So this is what the results look like. So at the top is the side effect of the medication. So this is looking at not the incidence of the blindness, but what's going on with Streptococcus pneumoniae carriage in your nasopharyngeal area. So we all know that a huge proportion, if not everybody, is colonized with Streptococcus pneumoniae, and Streptococcus pneumoniae is the leading cause of community-acquired pneumonia in adults. So carrying that organism becomes pretty easy to transmit, especially if you're a kid. So, but what about azithromycin-resistant Streptococcus pneumoniae? Not a common it's not that common to have macrolide resistant Streptococcus pneumoniae. So in the control group, in the people who were not treated every 3 months with 1 dose, it was 6% of the kids had macrolide resistant pneumococcus. In the treated group, before they got their first dose of azithromycin, it was 4%. So essentially equivalent to untreated. But after a year of getting 1 dose every 3 months, so again, you're getting not many doses, 46% of the kids had macrolide resistant Streptococcus pneumoniae. This is called selection pressure, where you've essentially selected for the resistant organisms. They were already there, but we just slowly killed off the non-resistant ones, and resistant ones flourished. And this is what happens when we overtreat. So if we look at antibiotic prescriptions per 1,000 persons in the US, 2020, so right before the pandemic, look at these red states. So you're looking at, on the upper end of this, almost 1,000. So what does that mean? It's 1,000 prescriptions per 1,000 people. So everybody gets, you get a drug and you get a drug and you get a drug. It's the Oprah of antibiotics. Everybody's being treated. And even on the low end, the very light in California, Hawaii, Alaska, Washington, on the low end of that 350. So 350 prescriptions per 1,000 people. And this is in the community. So it's ignoring what we're doing in the hospital as well. So the burden of antimicrobial use in the community in the United States is massive. It's massive. Globally, it's not any different. So you look through here, Saudi Arabia, South Africa, you're looking at about, up to 40,000 doses per 1,000 people. I mean, it's like almost unbelievable how much antibiotic is being used. But again, you have a lot of countries where you can go to the pharmacy and just buy. You don't need a prescription. You just say, I'm sick, I'm going to go get some antibiotics. So you get a lot more usage when you have less regulation in how you can acquire some of these medications. But overall, it's important to note that the utilization is massive. And even more critically here, if you look at the bottom, the gray area, no data, there is a huge amount of unknown of what's going on. So, and we are, again, we're a global, globalization is here. Everyone is moving, traveling, and transmission becomes pretty easy. We see when an organism pops up somewhere, it's pretty quick to get elsewhere. VA did a great study many years ago now, looking at what we had been doing with stewardship programs for a long time. And interestingly, they found in this big review that there's low strength of evidence that stewardship programs, the way we're doing it now, are actually doing anything. I don't know if you've noted this in your programs as you develop them, but what we've been doing, at least in the outpatient setting, has not been working. And it's not been working for 20 years. But what do we do about it? We definitely can't keep doing the same thing. We have to kind of think outside of the box and do something new. We can't ask somebody what to do. We have to do it ourselves. And one thing that I think is notable goes back to like the 60s when this book was released, Medical Innovation, a diffusion study. It was the start of this concept of diffusion of innovations, how anything new kind of flows through not just the community, but the world. How often do people pick up some new innovation and use them? You can think about this with, an iPhone or anything, but this particular study was looking at physician utilization of this brand new drug at the time, tetracycline, brand new drug. So about 2.5% of the population are innovators. These are the people that are, developing stuff, doing extremely novel things. Think, Steve Jobs back in his heyday. 13.5% are early adopters, so people that are always going to be doing something. The people that are waiting 3 days back in the day in an Apple store line to pick up the phone that Steve Jobs developed. Those are the early adopters. Early majority, a huge proportion of the population, people that are like, okay, yeah, I want this, but I'm not going to be waiting in line. Late majority, another about the same proportion as the early majority. I'm going to get it next year when it's $200 cheaper, or I'm going to get the when the iPhone 15 comes out, I'm going to get the 14 because it's cheaper. I want it, but I don't want it that bad. And then 16% laggards of, I'm still using my Nokia phone because that doesn't break ever. I'm not going to do this. So, but at the time, they're looking at this through the lens of antimicrobial use and how, who are the innovators, who are actually starting to use this drug immediately, who are waiting a little bit, and who just still are not going to use this drug. And what they found was that peer influence is absolutely critical, probably the most important thing. And you can probably see this in a lot of areas that, your attending physician told you this, or, whatever, the chief told you this, and this is just kind of what you do for the rest of your career. So we know that peer influence is critical, and we have to be able to intervene on that and identify the important people that can better influence their peers. It's identifying the key players in the network to help you get your message across, and not just get the message across, but get the buy-in for people to actually care about that message that you got across. So this study, great study about stewardship for 20 years. I mean, you can read through these, this is, again, just hitting the points that decision-making in medicine is a social process, and what those around you are doing is critical. It's not just about policies. You can make policies all day long, but that doesn't mean that they're going to be followed, especially if there's no ramifications. I mean, we've seen the failures of not having ramifications for hand hygiene and different types of things, so that it works the same with stewardship. All right, so let's talk a little bit more about what we're missing from our programs. So for non-antibiotics, I mean, think about, let's look through this through the lens of disinfectants. So just like antibiotics, we have a lot of different kinds of disinfectants. You've probably been in some meeting where you've tried to choose some new disinfectant, but probably EVS or somebody else hasn't really thought as much or brought to the table the idea of what you're trying to do with that. What's the purpose of this? Usually this is cheaper and it kills C. diff spores in 1 minute instead of 5 minutes. That's usually the level. But we have a lot of different compounds that work for a lot of different bacteria, for better or worse. So not everything works for everything. Definitely not everything works for everything in the same amount of time, and definitely not everything works for everything on the same surfaces. And resistance can work kind of the same way. So this is the kind of the general structure of different resistant mechanisms for antibiotics. So we know if you use a quinolone like ciprofloxacin or levofloxacin or something, it's working on the DNA gyrase. So they're going to modify that DNA gyrase, and it's going to prevent the drug from working. You can modify the different subunits of the ribosome to have resistance to macrolides or linazolid tetracyclines. We know that beta-lactams like penicillins work on the cell wall, so penicillin binding proteins get altered, and different drugs work, again, in different mechanisms. You can have efflux pumps or modify the cell themselves. Disinfectants are the same. So different disinfectants, just think about it like a drug. Just you're not taking it orally, you're putting it on a surface. So this is how different disinfectants work. So some work on the cell walls, some work on the ribosomes, some work on the gyrase. I mean, the corollaries are direct. Disinfectants work the same way. You have a couple of extra mechanisms of disinfectants, which are kind of good, but can also cause more problems. For example, just more chemical reaction as opposed to physical reaction. But again, we have to keep in mind that disinfectants and antiseptics are antimicrobials. So if we're doing an antimicrobial stewardship program, we should include them. Otherwise, it's an antibiotic stewardship program, which is fine. But we also have to keep in mind everything that we're killing. So our stewardship activities should be inclusive. And how do we do this? So we do a lot of this already without probably thinking about it through the lens of stewardship. But if we go back to this quadrant of the right drug, the dose, the duration, the route, when selecting the right drug, we know that we have to select something that's for the right surface. Is it a hard surface, a soft surface? Are we trying to kill something on leather or fabric? Or are we trying to kill something on a glass screen? For example, I think Bill Rotala did this study several years ago looking at privacy curtains. And you know that privacy curtains are, reusable ones are pretty gross. There's a lot of bacteria, a lot of different stuff on those privacy curtains. But prior to a couple of years ago, we didn't have any EPA registered disinfectants that were okay for soft surfaces. Now we have a couple. But you still don't have very much to select from. So it becomes a choice of, do you spend a lot of money for a soft surface disinfectant, or do you go a different route and use disposable curtains or something else, modify the environment? The right dose. So are you using a dilutable, or are you using something that's ready to use? Those are critical components, because dilution can cause a lot of human error. And also may not work as well. But so we did this study several years ago, looking at ready-to-use disinfectant wipes versus dilutables, and found that even though the cost of the ready-to-use, like pop-up wipe type of thing, was higher up front, it increased compliance, and it actually decreased costs over time due to the speed that you could turn things over. So the right duration. This is probably one that you are most familiar with, especially since when Joint Commission comes around, they usually ask you what's the dwell time for your different disinfectants. But it's very specific to the drug and the surface and the pathogen. So different surfaces are going to require different contact times. Different disinfectants are going to require different contact times, and different contact times are required for different pathogens, as you know. If you look at something that says kills whatever in 30 seconds, but kills C. diff in 5 minutes. We did another study similar to this, looking at hydrogen peroxide in the operating room. This was kind of one of the products that was okay for soft surfaces. So we wanted to test it on soft surfaces and hard surfaces, essentially everything. And we found that it worked very well. But when you have the same person doing the same room after every case, so the turnover, the compliance decreases. So there's another piece of the puzzle that we have to keep in mind, that when you're having this monotonous thing, compliance decreases. I mean, we know this from the human factors engineering literature back in the heyday of making people look at radars. After you're looking at a radar screen for 5 minutes, you're going to miss the big destroyer that goes across the screen, or that video of like the people bouncing basketballs and then the ape in the ape costume walks across the screen and like no one notices that it's there. It's because you've been distracted and bored with something. And the right route. So the application methods are critical. We know, especially this one, quaternary ammonium compounds, probably the most common disinfectant used in healthcare facilities because of its pretty good safety profile. Highest rates of disinfectant resistance. But if you use cotton rags with those, the cotton fibers bind the active ingredients. So when you actually end up wiping the surface, you're just wiping with water because all the compound is bound up into the cotton. So you have to use microfiber. So that application method becomes super critical depending on the different disinfectants. You always have to ensure compatibility with your different materials. And there's a lot of other dependencies too. I mean, the temperature, the pH, humidity, surface materials, organic matter. We've all heard the, dilutable bleach doesn't work if there's organic matter. Well, maybe it does, maybe it doesn't. What's in your water? Do you have all kinds of crazy water additives? Do you have super hard water? Those types of things might, if you're doing dilutables, might interfere with the ability of that drug to work or the disinfectant to work. And of course, biofilm. We know probably the biggest issue with biofilm is in your cooling towers. We deal with Legionella, and we pound them with heat, we pound them with chlorine, but of course, even with those types of physical and chemical ways to kill bacteria, we're still seeing not necessarily resistance, but reduced sensitivity, which is kind of the start to bigger problems. UV light doesn't solve it. Vaporized hydrogen peroxide doesn't solve it. It doesn't solve the biofilm problem because you need elbow grease. We know with antibiotics, the most effective strategy is de-escalation, reduce the spectrum of the drug to the most narrow spectrum so you don't kill all the normal stuff. The issue is all skin antiseptics and disinfectants are broad spectrum. We don't have anything to de-escalate to, and we don't always know what we're looking for. If you're in the middle of an outbreak, it's a little bit easier. If you had some disinfectant that you knew killed Acinetobacter and you're having an Acinetobacter outbreak, that would be a lot better, but we don't have that. There's a lot of things that we can do and a lot of things that we can try, but we don't really know what works. But we can't give up. We got to keep trying different stuff and see what happens. All right, so that's all I have for you today. I hope that was enjoyable.
Thanks so much, Dr. Wiemken. At this time, we're going to take some questions from the group. So if anybody has any questions, please let us know. All right, maybe folks are just absorbing all of the information that you just presented, Dr. Wiemken. So I want to thank everybody for attending this Grand Rounds, and we'll see you next week.